the intracanaliculaar part of the left facial nerve. The rest of the neuroparenchyma, there was no abnormal neuroparenchyma or meningeal enhancements in the brain and neural axis, sir. With these findings, sir, radiological impression of enhancement of intracanalicular segment of bilateral facial nerve was given. No abnormal neuroparenchyma or meningeal enhancement was seen, sir.
Thank you. So, as we had clinically suspected that this patient has bifacial involvement, element involvement because of the Bell's phenomena that we noticed, and that is easily demonstrable on the MRI. It is not every day that you find bifacial enhancement, the facial nerve enhancement. So, this is a very peculiar finding that we got in this patient. So, we have a hard concrete evidence through radiology also now that this patient has a bilateral lower motor neuron facial weakness. So, we now, if we start invoking those limited differentials of bilateral element facial nerve involvement, which we discussed earlier, then you have to investigate on those lines. And what is the lesion? The differentials are narrowing now.
But the investigations also revealed mild hyperbilirubinemia, mild transaminitis, and total protein albumin was not.
So, a presence of elevated transaminases suggests what?
It can be related to dengue also, and it can also be in Lyme's also.
Classically, when you have GPS-like presentation and you find the transaminitis is present, then you should think of viral etiologies like EMV, CBV. These are the things that can cause the SGOT, ALDST to rise. Lyme, as you said, Lyme can also cause, dengue can also cause, but the thing against dengue is that he has bifacial weakness and also he has no fever. There is nothing like dengue in this patient. Probably that IgG dengue that we got, IgG dengue. IgM dengue was probably a recent subclinical infection or maybe incidental finding. He had no hematological manifestation, no fever, nothing. So we will keep dengue as a remote possibility at this stage. And if it is dengue, then it is a case report that will be published in a good journal.
His ultrasound abdomen and KV was normal. CSF in analysis repeated at Command Hospital on 18th of November revealed acellular CSF with raised protein.
The repeat CSF has shown what the initial CSF did not show, which is albuminocytological dissociation. And why did the first CSF not show albuminocytological dissociation? Because it was done very early. It was done about a week later of the initial presentation. So you can miss this albuminocytology. Now, now that you got albuminocytological dissociation, is this GPS? It is not GPS. It is polyradicular neuropathy. GPS is a diagnosis of exclusion. If you rule out all other causes of polyradicular neuropathy, then you say this is GPS. Okay, so albuminocytological dissociation in a polyradicular neuropathy presentation is not GPS. You have to rule out all other etiologies. Okay, and the red herring here is that this patient had bladder involvement, which is very, 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 very rare in GBS. So that should always kind of irritate you as to what am I missing and what am I missing.
But the Lyme serology was done, which was positive.
So even though Lyme is a very, very rare diagnosis in India, we went ahead and did Lyme when it came positive, IgM positive, and is positive by a good margin. Ideally, to call it a Lyme disease, you should also do a CSF Lyme. But by this time, we had poked this patient twice for CSF, and for academic interest, we didn't want to. But otherwise, he fit into Lyme beautifully because he had this bifacial weakness also demonstrated on radiology, MRI, and he had a presentation that was typical of Lyme disease, clinical presentation, and now this serology also has come positive. Correct. Why did we do an ECG? Anyone? Yeah, can you get up and answer?
So Lyme's disease has conduction blocks associated.
It can cause first degree, second degree, third degree conduction blocks, and you may lose the patient because of this. So you have to do this ECG in every patient of a suspected Lyme. Some patients even require a pacemaker, and there are patients in US who go on telemetry, cardiac monitoring, to watch for any development of blocks, AV blocks.
He was managed with injection step naltrexone, tablet doxycycline, and injection enoxaparin for a DVT prophylaxis till the time he was bedbound. Presently, his police removed on 30th of November. He is ambulant without
About a month after his presentation.
yes after a month.
First presentation.
He is independent for activities of daily living.
So he's still not absolutely normal, but from bedbound state where his power was only 2 in the lower limbs, he is now able to walk independently, and he still has residual facial weakness, but he's improved greatly. Okay, move on.
Final diagnosis: polyradiculoneuropathy secondary to neuroborreliosis, Lyme's disease.
So we may think that Lyme is a rare entity. What is the Connecticut connection of Lyme disease? Lyme was first diagnosed in 1975, the year I was born. Talk of coincidences. In the county of Lyme. And that's how the disease gets the name Lyme's disease. This is in the Lyme County. And this is the kind of prevalence. You can see the North India is North India and belong to Jharkhand. We have traveled there. Possibility, and you will be surprised even the areas that are not shaded. There is a naval academy in Ishimala, and there was an officer cadet who developed Lyme's disease. Barnworth syndrome is a painful radiculatis due to Lyme's disease, and this was published in MJAFI. These are the notorious exodus ticks that can cause it. Lyme disease typically has an early localized disease where you have only cutaneous manifestations, and then you have early disseminated disease, which is probably what our patient had, and early neurological disease. And then you have late Lyme disease where you get arthritis, and here you can get encephalomyelitis kind of a presentation. This is a late disease and commonly seen in endemic countries, not so common in Italy, I've not seen. And the idea of today's clinic was to approach a case of a GBS-like presentation and think beyond the routine because of the red herrings the case had presented, and clinch the diagnosis by repeatedly observing and applying clinical reasoning. Thank you. With that, we come to the end of today's Saturday clinic. If there are any questions from the residents. Faculty.
Very nicely presented. Vinny, as usual, fantastic discussion.
Thank you. If there are no other questions, we come to the end of today's Saturday clinical meeting. Thank you for active participation and patience.